Good morning, everyone, and thank you all for joining us this morning for the Houston Methodist, DeBakey, and Heart and Vascular Center Grand Rounds. My name is Ju Kim, and I'm one of the heart failure and transplant cardiologists here at Methodist. And joining me in the studio today is Dr. Rayan Yousefzai, also a heart failure and transplant cardiologist. Before we begin this morning, I want to remind our audience to please interact with us by asking questions. There's two ways to do so. One is to go to pollev.com and enter DeBakey, or the other is to join by text by texting the word DeBakey to 37607 so that you can send in your questions. It gives me great pleasure and honor to introduce our Grand Round speaker this morning. We're really excited to have Dr. Daniel Burkhoff joining us to speak to us about the cardiogenic shock and how understanding physiology really has changed clinical practice. Dr. Burkhoff obtained his Doctor of Medicine and Doctor of Philosophy degrees from the Johns Hopkins Hospital School of Medicine and completed a fellowship in cardiology also at Johns Hopkins. He then moved on to Columbia University in New York, where he established and ran the Cardiovascular Research Laboratory through 2003, and then took the position of director of the Jack Skirball Center for Cardiovascular Research of the Cardiovascular Research Foundation through 2005. His focus shifted to development of research of medical devices in his capacity as medical director of several startup companies involved in cardiovascular diagnostics and therapeutics for heart failure. He then returned to CRF as director of heart failure, hemodynamics, and mechanical circulatory support research. In this capacity, he also directs the CRF's educational program called TEACH, Training and Education in Advanced Cardiovascular Hemodynamics. Dr. Burkhoff's interests include cardiovascular modeling and research in basic and clinical aspects of ventricular mechanics, cardiovascular monitoring, heart failure, and device and pharmacologic treatments for heart failure, including left ventricular assist devices. He's also the author of Harvey, an interactive simulation-based application available on the World Wide Web for teaching and researching many aspects of ventricular mechanics and hemodynamics. So it gives us great pleasure to introduce Dr. Burkhoff. Thank you for being here, and we're looking forward to your presentation.
Thanks so much for that introduction, and I'm really happy to be here today. And sorry that I can't be there in person, and hopefully in the next year there'll be changes to that. So Arvind asked me to talk about how cardiogenic shock and how understanding of physiology has changed clinical practice. And I think it would be a little bit presumptuous of me to actually say how it has changed practice. And what I think I'll really focus a little bit more on how it could change clinical practice. These are my disclosures. And so when we talk about cardiogenic shock, of course, we need to acknowledge that shock complicates about 7% of acute myocardial infarctions. Its incidence has not really changed in the last 15 to 20 years. It's associated with a 40 to 60% 30-day mortality. The only real significant advance in terms of a positive clinical trial has been the demonstration that early revascularization improves long-term survival. And that was provided by the shock trial, which was completed at the end of the 1990s. It's clear that the physiology is complex, and the lack of a myriad of required randomized trials really reflects the fact that it's very difficult to do research in this in the setting of acute myocardial infarction because of the acuity of the emergent nature of the situation. Now, what understanding of cardiogenic shock physiology have we actually gained? So if we want to answer the question, how has it changed practice, we have to first understand what understanding do we have about cardiogenic shock physiology. And every talk about cardiogenic shock physiology starts with this diagram, which is from Judith Hochman's work that accompanied the cardiogenic shock, the shock study, and this kind of outlines kind of the high level physiology of shock. When you start with an infarction, you have myocardial dysfunction. There are systolic and diastolic components to that, with a decrease in cardiac output, hypotension, decreased coronary perfusion, and worsening of ischemia. And then this whole cascade in conjunction with pulmonary congestion and hypoxia leads to progressive myocardial dysfunction and spirals to mortality. The decrease in cardiac output also leads to this decreased systemic perfusion and activation of the autonomic nervous system, which initially leads to vasoconstriction, both arterial and venous constriction. And subsequent to these earliest studies, it was really recognized that as the shock state persists, there's a systemic inflammatory response that actually counteracts some of these effects and actually worsens the situation by causing vasodilation, which worsens the systemic hypoperfusion. So this is when we talk about the physiology of cardiogenic shock. This is kind of the very high level explanations that we provide. But I think it turns out that we can get a deeper understanding if we look at the physiology through the window of the ventricular pressure volume diagram. And I'm not going to go through the details of this. This is probably very familiar to you. This is the ventricular pressure, left ventricular pressure volume diagram. It describes the events that occur during a single cardiac cycle. In particular, the 4 phases of the cardiac cycle: isovolumic contraction, ejection, isovolumic relaxation, and filling. And the valves open and close at the corners of this kind of trapezoid. Now, in terms of just a very quick overview of ventricular vascular coupling and physiology, I think that it's common knowledge now that the ventricular pressure volume loop sits within the boundaries of the end systolic and the end diastolic pressure volume relationships. And where the loop sits and how wide it is, which is the stroke volume, and how tall it is, which is the blood pressure, is dependent on the preload and the afterload and the contractility. So here we see changes in preload. As the preload is increased, the pressure generation, the stroke volume are all increased. This is the Frank-Starling mechanism that you know about. This is what happens when you change afterload. If you start out at a low resistance and you increase afterload resistance, the pressure goes up, but the stroke volume can go down. So, but again, the loops are constrained within the same boundaries. And it's only when there's a change in contractility that those boundaries can change. So here we have a reduction in contractility, as you would have with an acute infarct. And then you see that you'll have a reduction in the pressure generation and the stroke volume. And of course, also thinking about diastole, this is the line that on which the loops sit. This is the end diastolic pressure volume relationship. These can also shift. When this shifts leftwards, that's what we refer to as diastolic dysfunction. And this is very important in the physiology, the pathophysiology of things like restrictive cardiomyopathies, like amyloidosis. And when this curve shifts rightwards, this is a phenomenon called remodeling, and that underlies a lot of the physiology of chronic heart failure. Now, also in addition to mechanics, we also get a lot of information about myocardial energetics from the pressure volume diagram. The area inside of the loop is called the stroke work. That's the energy that the heart transmits to the blood to help it be propelled through the vascular system. But the total work that the heart does is the sum of that stroke work and this extra triangle to the left. And that's important. The sum of these two are called the pressure volume area, PVA. And that's important because pressure volume area is linearly related to myocardial oxygen consumption. So when we look at the effects of an intervention or a pathophysiological process, and we want to understand what's happening energetically, we look to see what's going on with the pressure volume area. Now, shock comes in many different flavors. And here what we see are right and left ventricular pressure volume diagrams. And here what we're illustrating is shock due to an isolated left ventricular infarction. So you see here that the right side contractility is not changing, but on the left side, the contractility is progressively decreasing. Typically what happens, there's an increase in wedge, and CVP can be normal or increased or can be decreased. But going along with the abrupt change in contractility is the baroreceptor activation, which causes increases in heart rates, the systemic vascular resistance, and the stress, and also importantly the stress blood volume. So note that even though the RV contractility hasn't changed, there are big changes in what's going on the right side, and that's all due to the changes in the wedge pressure that are affecting the afterload on the right ventricle, and also the lack of filling of the right ventricle because the left ventricle has decreased stroke volume, forward stroke volume. Now, another flavor of cardiogenic shock is isolated RV failure. And in this case, you see here that we're just having a decrease in RV contractility without an effect on the LV contractility. But again, we're having effects on the LV because the RV now can't eject enough blood to fill the LV. You have LV underfilling. The wedge pressure can be normal or typically can be decreased. And it's the underfilling of the LV that leads to the decrease in cardiac output and blood pressure. And again, you have the same baroreceptor activation and heart rate, SVR, and increases in stress blood volume. So that's isolated RV and isolated LV physiology. But more typically, there's a combination of involvement of left ventricle and right ventricle, and then things get a lot more complicated in terms of understanding how much of the abnormal pathophysiology is due to right and left-sided failure. And that's where having more advanced hemodynamic monitoring really helps to make the diagnosis and customize the care of the patients. And we'll talk about that in a little bit. But as a prelude to that, what we have been researching a lot and promoting is the concept of the pattern of congestion, where we plot the CVP versus the wedge pressure of an individual patient, and we can also track that during treatment. But what have we learned from looking at these kind of plots, what we've called the congestion profile? These are data from the Cardiogenic Shock Working Group that's being led by Naveen Kapoor at Tufts. And this has now several thousand patients, and this was an early report where we looked at the relationship between RAP and wedge pressure. And we divide this plane into 4 quadrants. You've got the euvolemic state, you've got left-sided congestion where wedge is elevated and CVP is normal. You've got bilateral congestion where RAP and wedge are elevated. And then you've got right-sided congestion where just the RAP is elevated. And what you can see is that fully 50% of patients fall into this bilateral congestion pattern. And one thing that may be a surprise, maybe not, if you're monitoring these patients, is exactly how high CVPs can go. We're seeing frequently CVPs above 20 millimeters of mercury, which of course is very extreme elevations, but is very consequential. What we looked at was the mortality as a function of your congestion profile, a patient's congestion profile. So here you have the euvolemic state, here you have left-sided congestion, and here the right-sided and the bilateral congestion. You see that the mortality in patients is double that if you have either euvolemic or isolated left-sided congestion. And the only difference the main difference between these two is really the CVP. In these two categories, the central venous pressure is increased, and that really is having a potent effect on mortality. That was true whether or not your shock was due to acute myocardial infarction or to decompensated heart failure. You see here that the trends are the same, that if CVP is elevated, you've got a higher mortality. The other thing that we note here, and this is another key point, is that the mortality overall is different between MI shock and heart failure shock. In general, for any one of these categories, the mortality is lower if it's due to decompensated chronic heart failure. So one key takeaway messages here is that most of the research that's been done in shock has been in the setting of AMI, and what we're learning more and more is that things that we've learned about AMI shock do not necessarily apply to decompensated heart failure shock. And that's particularly true about prognosis. With several indexes, we've seen that patients with lower predicted mortalities do fare better than predicted if they have decompensated heart failure shock. So it really speaks to the need for us to up our game on studying shock due to decompensated heart failure. Now, so that's a little bit of understanding about the underlying physiology, but what we really are a lot focused on these days is understanding the physiology and the hemodynamics of different therapeutic options. So of course, we've got pharmacologic therapies, inotropes, and pressors, and we've got a host of devices: balloon pump, ECMO, the LA to AO approaches like the tandem heart, percutaneous left ventricular assist devices like the Impella family of devices, and also we see a host of combination of devices like for example ECMO and Impella. And what we've been really focusing on is elucidating and proving the physiology and the hemodynamics of these different forms of support. So I'm not going to talk about the pharmacological aspects for the sake of time, and really focus on the hemodynamics of devices. And one of the key, another key teaching point, or let's say a learning point, has been that we know that the hemodynamic response to devices, just like it is to drugs, varies among patients. And we think that we've uncovered a lot of the reasons for that. And a lot of it, we think, has to do with the fact, obviously, that the baseline hemodynamic characteristics are very different among patients, and also that the secondary effects of devices are quite different. So for example, and I'll show examples of this, the response to device therapy varies depending on the degree of LV and RV compromise. And this can be very different among different patients. The short-term recoverability of LV and RV function can be very different. So the ability of the LV to regain function after therapy is very different if the shock is due to decompensated heart failure or if it's due to an acute ischemic event. The SVR and the PVR can vary dramatically from patient to patient, and the volume status is different. MR, the degree of MR, TR, and other valve lesions. So all of these factors and many more contribute to how a particular patient is going to respond to any form of mechanical support. And the number of combinations and permutations is literally infinite. So each patient, it can present like a snowflake where it has its own characteristics and therefore can have his own or her own response to any individual therapy. So these are now prototypical responses to various forms of therapy. You see here the balloon pump. The effect on aortic pressure is pretty well appreciated. In the pressure volume domain, you see that there's a relatively small effect. There's a small decrease in afterload pressure. The peak goes down. That reduction in afterload results in a small increase in stroke volume and a small reduction in wedge pressure. And it's clear from the randomized trials that that balloon pumps are relatively ineffective and really provide relatively little in the way of mechanical support in patients with shock. In contrast, you've got percutaneous left ventricular assist devices, where you can see here that there's, number one, really significant unloading of the ventricle. That's the leftward shift and the downward shift of the end diastolic pressure. And also the loop changes from a rectangle to a triangle. And that is because now these pumps are pumping blood from the ventricle to the aorta independent of the cardiac cycle. So we have loss of the isovolumic periods. And so that's what makes this triangular shape. And in the pressure time domain, what we can see is that depending on the degree of LV compromise and the speed of the LVAD, we can have LV aortic pressure uncoupling, where you see here the aortic pressure goes up and the LV pressure goes down, so that the aortic valve is no longer opening. And that contrasts with the physiology of ECMO, where under certain circumstances, the increase in afterload ventricle, which can secondarily result in an increase in end diastolic pressure and also then an increase in pulmonary capillary wedge pressure. So big difference in the physiology between LVADs and ECMO, and this has major implications on many of the aspects of the care of patients with these two different devices. For example, with an LVAD, it's okay for the aortic valve to be closed, and as we'll see in a little bit, with ECMO, the only way for blood to get out of the ventricle is for the heart itself to pump the blood out, and therefore a closed aortic valve is a very bad and ominous sign. And we'll come back to that in just a second. So here again is the physiology of ECMO. So we'll dive a little bit deeper here. And under these conditions where you have a fixed and significant reduction in contractility, I've already shown you that this can result in the increase in end diastolic pressure and wedge pressure. And we don't have clinical data on this, so we've turned to, in terms of the pressure volume loops, so we've turned to these simulations that we've been doing, these computer models that really have been shown to really faithfully illustrate the physiology that is present in humans. So here you see going from a baseline cardiogenic shock state and adding ECMO at various flows, what you see is that as the ECMO flow is increased, in this particular case, the end diastolic pressure increases. And here what you see is the left atrial pressure, also basically related to the wedge pressure, also progressively increases. Whereas, the good things about ECMO is you have the increase in aortic pressure and you have the decrease in right atrial pressure. So those are the good things that ECMO does for the body, but in certain circumstances, it can actually result in an increase in wedge pressure and an increase in the oxygen demand on the ventricle. So we don't have clinical data of this nature, but we do have data from preclinical models. And here you see a preclinical model. This is baseline pressure volume loops. This is now the shock state. And you see the marked reduction in the end systolic pressure volume relationship. And then this animal was put on to ECMO. And you see there's no unloading, and the end diastolic pressure is not decreased. And in this case, you see here the loop is basically almost a straight up and down line, meaning that the heart is not ejecting. And that relates to two other phenomena with peripheral ECMO, which are, first of which is the Harlequin syndrome, whereby if you are when you have peripheral ECMO, what you see on this aortogram is that when you inject dye into the thoracic aorta here, it does not reach the lower body. So this is showing that the heart and the ECMO are flow from the heart and the ECMO are competing with each other, resulting in a situation where the superior part of the body is being perfused from the heart and the inferior part is being perfused from the ECMO. So if your patient is in pulmonary edema, then this explains how you would be perfusing the superior part of the body with deoxygenated blood and the inferior part of the body with oxygenated blood. And this, of course, I'm sure those of you who are taking care of ECMO patients, you know that there are several things to monitor for this. For example, looking at the arterial blood oxygen saturation in the right radial artery, or looking at bitemporal near-infrared spectroscopy to look at the oxygenation of the brain. So this is one aspect of the physiology, but this now points out another aspect which relates to this issue of overloading the ventricle. And there are cases when the ventricular function is so low that the heart can't eject. And that results in the following things that all go together. One is you have fluid accumulation in the lungs. That's that left ventricular end diastolic pressure going up. You can either worsen or actually induce pulmonary edema by putting a patient on ECMO, as you see here. And that also then results in stasis in the ventricular chamber and also the left atrium in this case. And that, if left unchecked, can lead to thrombus formation. Oops. And here's another example of an echocardiogram of a patient on ECMO. And you can see here that how pinned that aortic valve is, totally pinned. And you see the stasis, not only in the ventricle, but the aortic root. And this can then lead to thrombus formation inside of the aortic root. So these are some of the basic, let's say the basic physiology. But now let's return to the concept that I laid out before, which was that the response to therapies varies among patients because of many factors. And now I'm just going to show a prototypical response in a patient who had shock on the basis of ischemia, myocardial ischemia infarction. And once blood pressure is restored, the contractility increased. So here you see now, as and this is obviously not in real time, but in fast speed, but you see as the perfusion pressure to the heart is improved, the contractility is increasing. And when this happens, the heart is able to overcome that increase in pressure, and we don't see the same degree of ventricular loading. So again, this emphasizes that the response to any form of therapy is not one thing. You can't say ECMO always does this to the heart, and it really speaks to the need to monitor what's happening with your particular patient, so that you can detect early whether or not ECMO is doing is increasing the load on the heart and on the lungs. So how do we contrast that with percutaneous ventricular assist devices? So again, I already kind of gave a highlight of this physiology. Again, you see the unloading of the ventricle. Remember that the oxygen consumption is related to that pressure volume area, this whole area here. So this results in a decrease in myocardial oxygen consumption. We've talked about the loss of the isovolumic phases of the contraction. So we have a triangular shape loop, and we've also talked about the ventricular aortic pressure uncoupling that can occur. Now, the degree of uncoupling or whether it uncouples is dependent on how weak the heart is and how strong the ventricular assist device is. These are some real loops. These were measured by Bill O'Neill. This is during a high-risk PCI case, but nevertheless, these are human loops. This is without an Impella device. You see this trapezoidal shape that we've been talking about, and this is with an Impella 5.0, and you see the triangulation of these loops. And also this patient received a shot of nitroglycerin, which modifies the preload and the afterload. And you see that at end systole, the end systolic and the end diastolic pressure volume relationships that we've been talking about are marched out. And again, this is the preclinical model that I showed you before. I showed you the ECMO physiology at the bottom here, and that contrasts with the percutaneous ventricular assist physiology. So here we've got the baseline, these tall upright pressure volume loops. The shock state, you see the marked reduction in contractility. And then during CP, this is Impella CP support, you see that there is this triangulation of these loops. And also note that in contrast to ECMO, the end diastolic pressure has decreased from 30 millimeters of mercury to about 20 millimeters of mercury. So on average, you see here that there is a 10 millimeter reduction in the end diastolic pressure, which correlates with clinical results showing a similar around 10 millimeter on average reduction in pulmonary capillary wedge pressure with the use of a percutaneous left ventricular assist device. Now, like we saw before, the response to percutaneous VAD support can also vary among patients. Again, here we're just showing the illustration when the contractility has reserve, and when you initiate support with a device, the contractility is increasing, and this does have a significant impact on the response. Number one, there's a greater degree of unloading. In this case, the heart and the pump are working together, and you have a greater degree of unloading. Second, you see here, in contrast to what we had before, you don't have that pressure, aortic and ventricular pressure uncoupling, because now the pressure in the ventricle is increasing, and certainly the pressure in the aorta is increasing. But in this case, the heart and the ventricle the heart and the ventricle and the device are such that the relative speed and flow and contractility are such that we don't have that pressure and ventricular pressure uncoupling with the aorta. So again, another illustration of how response to therapy can vary among patients. So that's a brief overview of what we've learned about the physiology of left-sided support. Well, what have we learned about right-sided support? So this is now the example of isolated right ventricular infarction. And we saw the physiology that I showed you before, that we've had at the start, we had a reduction in RV contractility without a change in LV contractility. And as a result of that, the basic physiology was that the LV was underfilled. Whoops, I'm sorry, hold on. The LV is underfilled. And that is kind of the basis for the systemic hypotension, underfilling of the left ventricle. Now, when we implant a right ventricular assist device, in this case, taking blood from the RA and pumping it to the PA, the main thing that we do is we bypass the right ventricle, and we now are pushing blood through the pulmonary artery to be oxygenated, but also, more importantly, to fill the left ventricle, and that is what restores the blood pressure and the cardiac output to the systemic circulation. Another common example of right ventricular failure is what happens post LVAD. So when patients get either a temporary or a durable LVAD, it's not uncommon. It happens in around between 15 and 20% that a degree of right heart failure is realized. So in this loops here, what we're showing is what happens if you put an LVAD in a patient who has biventricular failure. And what you can see is the LV is being unloaded, but because the RV is weak in this case, it cannot keep up with the increase in the flow that the LVAD is providing. The RV is getting overloaded, and secondarily, the LV is becoming unloaded. And that results in a lot of the complications that we see with LVAD support in biventricular failure. For example, the underfilling can result in suction events on the left ventricle, because now the LV is too small. You can have arrhythmias, you can have decreased flow because there's not enough venous return to the left side. You can have hemolysis just because the anatomy is now making the flow characteristics into the VAD unfavorable. And also, of course, you have this further increase in right ventricular and diastolic pressure, meaning that there's another marked increase in central venous pressure and RV and diastolic pressure. So here's what happens now if you add a right ventricular assist device to a left ventricular assist device in a patient with biventricular failure. Again, we're bypassing the RV. We reduce the central venous pressure. We reduce the RV and diastolic pressure, and now we can fill the left ventricle. One thing that you have to be careful of is to balance the flows from the right and the left side devices when you use biventricular support, because you have the possibility to actually overflow, because now you're controlling the relative strengths of the RV, of the RVAD and the LVAD, and you can actually overflow the left ventricle. And we've seen cases where left ventricular and diastolic pressure can be overfilled during these cases. So another reason to use hemodynamic monitoring to make sure that you're adjusting the flow of the relative flows of these two devices. So let's return just for a second now to ECMO and the need for LV decompression. As I showed you, the response to ECMO is variable. In some cases, it can lead to marked increases in wedge pressure. In other cases, it doesn't. But what do you do when it does lead to increased wedge pressure and increase in end diastolic pressure and aortic valve closure? Well, it turns out that there are at least 8 ways to decompress the ventricle and get the heart to open the aortic valve. I'm not going to go through all of these in detail. I think it's important in managing these patients to know all the options and to know when they're applicable, and perhaps more importantly, what their individual limitations are. They each have a role in clinical practice, but they also it's really important to understand their limitations and when not to use them. Only one that I wanted to highlight, because it has become relatively popular, is the combination of ECMO with a left ventricular assist device. And here you see that the addition of a left ventricular assist device, in this case where we started from, completely can counteract that loading that the ECMO can do. And in this case, what we've done is we have now working the ECMO and the LVAD kind of working both in full speed. And what you now have are 2 pumps working in parallel. So you've got a lot of flow, and ordinarily you would not adjust things so that the pressure would be this high. So now once you use these 2 devices, again, you need to adjust the relative speeds of each device to optimize the blood pressure and to optimize the flow based on the needs of the patient and also the oxygenation needs. But once you have these 2 devices in place, the question becomes, how do you adjust them? And also, when you start your weaning process, which device do you wean first? And there are a host of different practices around the country, and there's no standardized way of doing this. But I think a lot of the consensus is that it's very helpful to know what your hemodynamics are while you're doing these weaning processes. This is a real case. This is a patient who presented with shock, had a wedge pressure of 40, was in frank pulmonary edema, was crashed onto ECMO, and you see here that the wedge pressure increased further. This is exactly the kind of patient with that degree of dysfunction that you would expect that ECMO would further exacerbate the pulmonary congestion. And the investigators were prepared, and they rapidly then put in a percutaneous device. And you see here how quickly and profoundly the left ventricular unloading was achieved with this strategy. So I mentioned before that I think that sound understanding of hemodynamics and physiology can help guide the escalation and management of patients. And again, I just want to return for a brief second to this plot of the congestion profile, because I think this, at least for teaching purposes, can illustrate other aspects of the varied responses to ventricular assist in cardiogenic shock. So here's one patient who presented with predominantly a markedly elevated wedge pressure and an only mildly elevated CVP. We're using the open dots to indicate whether the cardiac index is greater than or less than 2.2. And in this case, the open circles are when the cardiac index is below 2.2. So this is a common response to the kind of garden variety left-sided cardiogenic shock, where the patient presents with left-sided congestion predominantly. You put in your ventricular assist device, the wedge pressure starts going down, the cardiac index starts going up, and also you see your CVP going down as well. And the CVP goes down for 2 reasons. One is that you are, by reducing the wedge pressure, you're decreasing the afterload on the right ventricle, so it can eject better, and that reduces the CVP. And in addition, we shouldn't forget that increasing the blood pressure and increasing the perfusion of the kidneys results in an increase in urine output. So we've got now two reasons. We're addressing the volume status issue, and this is a kind of smooth sailing, a typical left-sided infarct, uncomplicated, where you put in an LVAD and both wedge and CVP go down, and the cardiac index it normalizes. Here's another case of a patient which had more profound bilateral congestion. An LVAD was placed. Cardiac index went up nicely. Both the CVP and the wedge decreased. However, the patient remained with elevations of both CVP and wedge. And this is a reminder that even though you put in devices, you can't always compensate for the volume status. And in this case, the patient was administered diuretics and appropriately administered diuretics because during the period of shock, the volume status increased due to relative hypoperfusion of the kidneys. And then in this case now, you see that that both the CVP and the wedge went down. So this is a case of persistent volume overload after providing a left ventricular assist device. And this patient is a bit more complicated in that patient presented with predominantly a marked elevation of the CVP in shock. A left ventricular assist device was placed initially, and the wedge pressure went down, but the CVP actually went up more. And so it was appreciated that there was a significant contribution of right-sided RV dysfunction, and an RVAD was placed. And then in this case, the CVP went down a lot, but that worsened the wedge pressure. This is what I was talking about before, that you can overflow the left ventricle with an RVAD, even when you have a left ventricular assist device in place. So in this case, what happened was, again, patient, this also can be indicative of not only potentially an imbalance between RVAD and LVAD, but also a persistence of a hypervolemic volume overloaded state. And you really need to always keep in mind that even with two devices, you cannot compensate for a hypervolemic response. And it implies, it indicates the need to actively manage volume status, either with diuretics or with renal replacement therapy. So these trajectories march out three different patterns of response to mechanical circulatory support. Again, it highlights the variability, and this is just three examples. There are really a large number of examples, different patterns of response to therapies. And we found that, at least again from a teaching point of view and from an understanding point of view, these diagrams are quite informative in indicating the physiology of what's going on. So if we again go back to the original question that was posed, how understanding of physiology has changed clinical practice? Well, first of all and foremost, I think that understanding of the physiology has clarified the hemodynamic effects of different forms of mechanical support and implications for patient care strategies and mandates. We understand the implications of aortic valve closure is different in an LVAD than it is in ECMO. With ECMO, a closed aortic valve means stasis in the ventricle and in the aortic root. With a percutaneous ventricular assist device, you're maintaining flow within the ventricle and the aorta, so you don't have to worry about aortic valve closure. We understand a lot about the potential for and why you have pulmonary and LV loading with ECMO, and why you don't have that with a left ventricular support device. We also understand the implications of these various approaches to myocardial energetics. We didn't emphasize it during the talk, but if you're in a myocardial infarction situation, you put ECMO on and you increase the pressure volume area, that can increase the oxygen demand and has the potential to increase infarct size. Whereas if you put a left ventricular assist device in, that pressure volume area decreases and you reduce the oxygen demand. And that maybe can have some infarct sparing or infarct, a limitation of infarct size. So that's first. Second, the understanding of physiology has helped clarify why there are variable responses to different forms of MCS, why not everyone requires LV unloading during ECMO, and clarifies the 8 different ways of LV unloading during ECMO, and in particular clarifies, since we'll never be able to find these out, I don't think, in clinical trials, it really clarifies the advantages and the limitations of each of those. Our understanding clarifies the hemodynamic basis for mechanical circulatory support escalation strategies and how we you combine various different devices. We just talked about 2 possibilities, but there are many other possibilities. And I think first and foremost, this understanding really underscores the need and the benefits of using pulmonary artery catheters to guide therapy in cardiogenic shock. And I think it really, again, all links back to the variability of the response. You cannot reliably predict how a patient is going to respond to one form or another. You can't predict if your initial strategy is going to be adequate or not. You can't predict if supplemental device combinations are going to be required. And you cannot, and I think one of the other principles in cardiogenic shock that we're learning is that time is the enemy. The longer a patient persists in shock, the greater the odds that they're going to go into that systemic inflammatory response pathway and lead to metabolic, in addition to hemodynamic shock with multi-organ dysfunction and leading to multi-organ failure. So I think the concept not proven by clinical trials is that the quicker you can get a patient out of cardiogenic shock, probably, all else being equal, the quicker you can get a patient out of shock and address their hemodynamic deficits, the better off they will be. So I think in the end, what I think how understanding has changed practice is really boils down to this statement that knowledge is power, which I think really was attributed originally to Francis Bacon, the British philosopher of science, which was often also attributed to Thomas Jefferson in many of his speeches. So I'll stop here, and I hope that this was informative. We reviewed a lot of basic physiology, and I think that you can see that over the last, all of these hemodynamic and physiology understanding has been elucidated over the last 5 to 10 years. I think that, in the 80s, when I went to medical school, we learned a lot of this stuff. Most people, forgot it very quickly. Then there has been a dearth of education. The education in hemodynamics, declined through the 90s and the early 2000s, and now I think it's almost non-existent in medical schools or very minimal. But over the last 5 years, I think that we've seen the value of educating people in hemodynamics, because I think in the end it does have an impact on clinical practice. So I'll stop there and look forward to having some discussions.
Thank you so much, Dr. Burkhoff, as always, the amazing and enlightening talk. I have a question about the use of the catheters. So we are heavily, as of now, rely on using the PA catheters, which makes us more think about pressure and flow rather than energy and work and myocardial demand. And I know there are some of the catheters that are mostly used in the research arena for us to have a better understanding. I want to get your thoughts on that to see if there's any new technologies in the pipeline that are coming and there, where you see the future of this technology for us to have a better understanding of the myocardial demand and unloading and energy rather than just the pressure and flow?
Yeah, that's a great question. I think the catheter that you're referring to is called the conductance catheter. It's a catheter that goes into the ventricle and uses, in essence, a intraventricular bioimpedance to assess ventricular volume simultaneous with high fidelity ventricular pressure. The use of that catheter really has been, isolated to the realm of research, and it has been used in a wide range of situations, and not as much in cardiogenic shock because of the acuity of the situation, but in understanding things about high-risk PCI, standard ventricular assist devices. We're learning now, we're using it in the right ventricle to understand much more about right ventricular physiology. So I don't think that there are any other invasive technologies that are gonna emerge at this point. But what we are seeing is enhancements and advances in non-invasive imaging, 3D echocardiography, and the use of artificial intelligence to analyze and imagery and automatically segment the images are making significant advances for us to get to that elusive ventricular volume and volume over time. And I think that there will be a possibility to combine over, as these technologies become more easier to use, we're going to see more non-invasive assessments of pressure volume relationships. We, in our own research with many colleagues, we're looking at non-invasive approaches to getting this information. So I think it is valuable, as you've seen, and I think that we will be seeing over the coming years more applications, more papers about non-invasive pressure volume analysis.
Thank you.
Thank you, Dr. Burkhoff. We have some questions coming in from the audience, and I'll read the first one. It's from Arvind, and Arvind says, "Thank you for your wonderful talk and elegant as usual," and he apologized he couldn't be here to host you himself. But he has two questions for you. The first is, during weaning a Impella 5.5, it says he finds it difficult to estimate the ability to remove that device with static hemodynamics without having the ability to estimate the cardiac power output of the heart independent of the Impella. Sometimes everything seems to be going well and the patient crashes. So how would you go about using physiology to try and use things like cardiac power output to wean support devices such as an Impella?
Yeah, that's really a great question, and I certainly don't have an answer that's readily applicable at the current time. There are efforts underway, and maybe you're aware of these, to integrate information from the Impella itself, as well as the patient's, the right heart cath information, to understand what component of the total cardiac output and the total power output that you're seeing is due to the device and is due to the heart. And also, we ourselves are trying to use our simulations to take that kind of information, what the pump is doing, and right heart cath data, and then predict what would happen if you remove the Impella. So to try to back calculate the ventricular contractility and its ability to support the circulation on its own. There are efforts that are ongoing, maybe with the Smart Assist console, using artificial intelligence. These are all research efforts, and we have our own efforts in trying to do these things. Again, by integrating right heart cath data, and echo would be, is another helpful complement to that, I think. And also understanding the performance of the device at that time. So I think it's a very important question. We want to go beyond just trial and error, and actually to be able to generate prediction metrics that will let you know the probability, at least, of being able to wean a 5.5. really a critical question these days, especially with the if you're thinking about transplant and with the transplant allocation system now, where there appears to be less bridge to recovery applications, and patients are getting transplanted on these devices, maybe too quickly. Not sure if that's the right way to say it, but I think having a way to predict whether a patient's heart can recover and support the circulation would certainly have several advantages.
And certainly predicting outcomes after certain interventions is always going to be challenging. But for us as heart failure cardiologists, one of our remaining challenges is the right ventricular failure after a durable LVAD implant, as you alluded to in your presentation. What are your thoughts on, the various predictors that are out there, the CVP to wedge ratios, the POPIs, the Euromax scores, all of these tools that we have, but none of them remain perfect. So what are your thoughts on the role of understanding of physiology and energetics to really guide, better prediction for right ventricular failure after a durable LVAD?
That's a really great question. There are, at least now by my count, 6 different indexes of RV failure. At one center I was visiting, they calculate all of them, and none of them, they rarely, never do they all give the same answer. And usually, 2 give one answer and 3 give the other, and the concordance is different among different patients. So it's clear that we don't understand when right heart failure occurs. I think that my feeling, and we've been doing a lot of analyses of this, starting with preoperative hemodynamics, and finding it very difficult to explain solely on the basis of hemodynamics who is going to and who is not going to have right ventricular failure. So I suspect that there are procedural issues that happen during the implant of especially we're talking now about durable VADs, that there are intraprocedural factors, like we know, like the amount of blood products, whether there's air embolus to the right coronary artery, whether the duration of the surgery, and the duration of the if it's put on bypass, the role of the pericardium. So we're learning more about left lateral, less invasive implant instead of a sternotomy with full pericardiectomy versus lateral strategies that spare the pericardium. We ourselves are doing a study on interventricular interaction using the RV pressure volume catheters to understand the role of interventricular interaction, which is always quoted as one of the major things, that you unload the LV and that makes the RV less contractile. So we're specifically addressing that one component, both by direct measurements and incorporating our learnings into simulations. So I think it's it's very complicated. I don't think that the current indexes are useful, and I think you always have to be on the lookout for early right ventricular failure, and I think it's going to take a while before we really nail that one.
Thank you. I think there are a lot of questions are coming, but I think we probably have time for one more question. And as a center that we still use a lot of balloon pump, there's a question that's coming that there's some published data recently for especially for a subset of the patient with a non-ischemic heart failure who are super responders to their balloon pump. And we want to have your thoughts on how we can predict who will be a responder to a balloon pump, and what are your thoughts about still role of the balloon pump and decompensated heart failure?
Yeah, another really, really hot topic, which there is no great answer for. It is true that heart failure cardiologists let me take a step back. This links to what I said very early on, which all of the randomized trials and most of the research into mechanical support really deals with AMI shock. And there's a paucity of data on heart failure shock. And it's clear that what we learn from AMI shock does not one-to-one translate to heart failure shock. So there is this sense among especially among heart failure cardiologists, that balloon pumping is more effective in that setting than it is in AMI. There are the evidence that fuels that concept is all registry data, retrospective analyses, including data from Columbia that we participated in. It's all retrospective and registry type data. So I would not use that as level 1A evidence. We do not know the way we know in AMI shock the role of balloon pump. I think it's really a great topic for future research, and I know that there are some protocols that are being discussed to do a randomized trial of balloon pump versus a ventricular assist device in decompensated heart failure. The hemodynamic factors that we would have thought would make a balloon pump more effective include vascular stiffness. So you would think that in a patient with a stiff vasculature, when the balloon pump pumps, it would be more effective because less of the energy would go to distending the aortic wall and in a sense wasted, and would be more put into increasing forward flow and reducing the afterload. However, when we look at those kinds of indices of vascular stiffness, it is not correlated with who is a super responder and who's a non-responder. So again, I think we don't know. You would think that it would be something so mechanical in nature that we would be able to figure it out. But I don't think that we know the answer. So until we have randomized trials, and everyone, even before we had the IBP Shock 2 study, everyone clung to their patients that they saw where balloon pump worked really well. So it can work. The question is, in what percentage of patients does it work? And how long do you let a patient exist with that pump, with a balloon pump, before escalating so that you can actually achieve the hemodynamics that you want to achieve? So again, I think this is where right heart cath monitoring can come in. There's no need to put a balloon pump in and wait for 6 hours or 12 hours or 24 hours to see if it's working. You can know in a half an hour whether it's working or not. And if it does work, great. If it doesn't, escalate. And my bet would be that it probably works, quote unquote. Super responders are rare, but it may work in 25%. I don't know the number, but I'm just going to make up from the paper that we looked at, maybe 25% or 20% or 15% super responders, and the rest of them, it doesn't really do much. You see that on average in the literature, balloon pump increases cardiac output by 0.5 liters per minute. That's on average. So that means there's going to be better and less, better and worse responses. So it's a great topic for research.
Thank you.
Thank you, Dr. Burkhoff. I think this has been just a fantastic discussion. And one of the key takeaway points for me, at least, is your statement that not all shock is the same. What we know about acute MI shock does not apply necessarily to heart failure shock. And a lot of the questions that we unfortunately did not have time to address, I think gets to the point that all these tools, whether it's inotropes, vasopressors, and mechanical support, have their role, but really early identification and clarification of the profile, or what flavor of cardiogenic shock that we're dealing with, really dictates our management strategies. So Thank you very much again for a wonderful talk, and we wish we could have had you here in Houston, but we really appreciated your time, and thank you very much.
Thank you very much for having me, and I do look forward to visiting you soon.
Thank you.
Thank you.